These two are passive atelectasis examples. And passive happens either from pneumo, hydro, or fibro thorax. And the term pneumo is air, hydro is liquid, fibro is scar, and the term thorax means it's in the pleural space. In the pleural space. And those are the three that cause compressive or passive. Now over here, there's a blockage in the bronchus. The bronchus is physically blocked inside. And so the lung is actively collapsing. Here, there's nothing wrong with the lung itself. It's just in the way. It's just in the way. So let's look at this one. We have two density changes here, don't we? Mm-hmm. Unilateral localized water, because this doesn't look like this, does it? So we've got unilateral localized water, and we've also got unilateral hyperlucency of almost the entire hemithorax on the right side. So we've got two density changes. You see that? All right. Hyperlucent and no visible what out here?
No
Vascular.
No what?
Vasculature.
No blood vessels. So the rule is hyperlucency and no visible blood vessels equals no lung there. Because if there's lung there, there needs to be blood vessels there. See? We've got hyperlucency, but we got blood vessels. We've got really hyperlucency and no visible vasculature. So what's happened is this patient now has air in the pleural space. There is no space in the pleural space. They're up against each other. There's a little bit of fluid so one can move, but there's a vacuum in there holding the lung against the chest wall. So the two layers of pleura are in contact. If you have something in the pleural space, the lung will lose volume by the same amount. So you got X volume of air, you got to have X collapse of the lung. So this is the lung. This is what's left of the entire right lung, all three lobes. There's nothing wrong with the bronchus. Nothing wrong with it. This is taking our water bottle and squeezing it. That's what happened here. Now we lost the volume. This is putting your mouth over the water bottle and sucking on it. The thing collapses. This is just externally squeezing it. And you can squeeze it with air, you can squeeze it with water, or you can squeeze it with scar. But scar can't do this. Scar is not going to give you hyperlucency, and hydrothorax isn't going to give us hyperlucency. Hydrothorax, this thing would be completely opaque, because it would be a liquid. This is a pneumothorax causing passive atelectasis. There's also a little bit of blood in there. In fact, that's actually not a little bit. That's probably 300 to 500 milliliters of blood back there. How about this one?
Does that mean this lung cannot expand anymore?
Not with the air in the pleural space, it can.
But once you take care of that, it
This has
can...
got to come out of there, and it's got to come out of here fast. Because tension pneumothorax, which is what this is, kills people. And it can kill people really fast. And here's how it kills them. Because this is the left lung, notice, hyperlucent, no visible vasculature. We also have no what over here?
No heart.
No heart. Where's the heart? Well, there's the trachea. Being pushed slightly away. Yeah, it's supposed to be here. You can't move it up here, but the thing's going to move like it's hinged, like this. So the trachea went here. By extension, what else went?
The heart.
The whole mediastinum has moved, yes. So the heart went all the way over to here. If you push the heart up against the chest wall so hard that the chambers can't fill, how much time do you think you got? You got a heart that can't pump now because the pressure is so strong around it. It's trying, you can't get any blood because the pressure, it's like tamponade. The pressure is so strong on the chambers you can't get anything in them. And this is how people die from pneumothorax. And you can go from a normal lung to this very quickly, depending on how big the leak is. Okay, and we'll talk about pneumothorax in the 10th quarter class, next quarter. And it is a killer, and it kills people real quickly. Every day, all over the planet, people die from pneumothorax.
So the lung on the right will return to its normal size once the air is taken out of the pleural
Yep,
space?
the whole thing can go back to normal. The whole thing. This patient has to have what's called thoracentesis. They make an incision here, stick a tube in, and start sucking the air out. And as soon as you get this back to negative pressure, this will go back like this, and the lung will go back to the chest wall. And it can happen real quickly. But you got to get the air out of there. Or this patient can go from looking like this to looking like this. And there's no way to know how fast this is happening.
This came from some sort of accident where the chest wall was punctured?
It can be.
Everyone
It can be from rib fractures. It can be from gunshot wounds, stab wounds, or coughing and sneezing. And somebody who has a pneumothorax with no external wound through the chest popped a bleb from coughing or sneezing. Those people can end up in a chiro office. We've had them in the clinic. I've seen them in chiropractic offices. We had them when I was doing my radiology training. Those people walk in and they complain about a little discomfort in their shoulder and chest area and progressively worsening dyspnea. They don't have any open chest wounds. They coughed or sneezed. The patient that's got a stab wound, do you think you're going to see those in an ambulatory care chiropractic office? No, and we shouldn't be seeing them anyway because they need to be in an emergency room. But somebody who coughs or sneezes, absolutely they can develop a pneumothorax. And it's they pop a bleb, and we'll talk about how people get blebs next quarter.
More prone to having it happen again?
Mm-hmm. Yes. And the typical individual that pops a bleb is usually a young adult male, tall, thin. Okay, so this is passive atelectasis. And over here, remember, in resorption, the two layers of pleura do not lose contact. Remember? We made a big deal about that in the lecture. It slides along it, but it doesn't pull away. Did this pull away?
Yeah.
It has to, because you separated the two layers of pleura. So they're very, very different types of atelectasis, but they're both volume losses.